Dr. Sang Do Shin.
Thank you very much inviting me to talk about this interesting topics. Actually, the medical science and medical practice are led by the physician usually because the doctor and physician is the only guaranteed by the people, guaranteed by the society to take care of the patient. But pre-hospital care and community care and emergency services are working together with non-physician providers. During the several decades, the physician and the non-physician providers working together to provide high-quality care in pre-hospital setting and then community setting. But nowadays, we are looking at our system. What's the role of the physician in pre-hospital and community care? I'm very surprised to see here that Thailand is one of the best example to work for pre-hospital care by physician. That I've been many places to benchmark EMS, and then Thailand is one of the prototype to show how can physicians can work together with pre-hospital care providers, not only for emergency care, but also the other public health program. So today I would talk about the physician-directed resuscitation. It is not new one. It is already physician is directed resuscitation program for the rest several decades. So what is change? Okay, this one. Okay, I'm sorry. Yeah. Click one. Yeah, and then. Okay. So I will talk about the COVID-19 and broken EMS, and then I will talk about the resuscitation concept changing for the rest of 50 years. And then what is the next direction in terms of the physician-directed resuscitation? The pandemic is not new one, but broken everything in the emergency care in every country. In Korea, also we had many difficulty to provide emergency care from the hospital setting, and also pre-hospital care providers very support from the burden and the isolation and delivery the patient who are potential infected to the COVID. That from the situation, the EMS systems are really broken, and the most systems are not clearly linked. And then from that situation, many patients not saved. During 3 years, we reviewed and then go back to the past. And what's happening? What's the change for the 50 years of the resuscitation? Now we want to look at, and then we can get the lesson to see what's the next generation of the resuscitation. So I will talk about that reality. I will talk about the perspective or the emerging opportunity in terms of physician-directed resuscitation. Okay, since 1950s to 1990s, this concept of the CPR was introduced. 1950s, ABC, everybody know. And then mannequin, the radar, is outside the classroom. And then pioneers developed the defibrillator. And then they used the phone for early access. The first concept is ABC. ABC means how can we save the arrest people? So airway and breathing and circulation. It can guarantee for people who collapsed can be saved. And then people transfer knowledge and skill to the other providers, in particular non-physician extenders, which are paramedic and nurses working the pre-hospital care, using the protocol and education and quality assurance, which is the medical direction. After the 1990s, there are some changes that they are focusing more individual CPR performance. So they developed some concept A, B, C, D, order, and then evenly distributed for the importance and priority. Airway and the quickly breathing and circulation. And then if you have some availability to defibrillator, in late 1990s, the public AED introduced in some advanced country. So public AED is one of the important solution for care the patient in the community. So ABCD, at that time, when I was a resident, ABCD is one of the Bible. We should learn 15 to 2, 30 to 2, 15 to 1, which is better, 5 to 1. Children is 5 to 1. Elderly, how many times breathing, how many times compression? It was very important issues. And then from this concept, many scientific researchers, investigators do research and report which is better, which is wrong, which is a favor the outcomes. After that, there are some changes because we have developed a new concept that individual CPR is important, individual knowledge and skill important, but it should be provided by the team, because at that time we had many animal study. Animal study showed that how can we provide continuous flow to brain without any interruption. So the one person cannot provide everything. The one or two or three person, on the basis of a combination of the providers, should provide without any interruption of the care, they provide perfusion to brain and also coronary perfusion. It is very important conceptual change. So since 2000 to 2010, the team CPR is one of the new Bible. So from the basic study and the light picture is from the clinical study, they can find how can we provide optimal perfusion without any interruption. It only can be achieved by the team, not individual. So team CPR is a very important direction. So everybody are trained, and the team CPR in the pre-hospital, team CPR in the hospital, and then it can make sure to provide continuous flow to brain. This is one of the examples. How can we develop CPR team in the hospital? One of the guy in the United States, Ben Barbaro, is designing the new concept in the whole community, the Arizona state. They developed the team CPR and the program to minimize the brokening and interruption of the CPR, which was a share program is implemented in the Arizona whole state, and then get the better outcome. So this is a very good example, and many countries, many scientists benchmark the program. Team CPR makes save lives and much better outcomes from this project. So from this kind of trial, ABCD changed now. CAB, compression is much important. Airway, okay, but we have enough oxygen for a minute. And breathing is also good, but compression is much more important. So concepts change from the ABCD to CAB or CDAB. Another one is the circulation is more strongly recommend rather than the other A or B. So circulation means for the rest of several decades, we have not solution for giving the enough circulation to the brain within 10 minutes and 20 minutes. It's a very critical time, but we have no solution. We have only hands at the time. Now we use the compression devices, but it is equivalent to the hands only. It is not make better circulation. Only we can provide the equivalent flow to the brain. The magic hand is man's hand. So from this concept, ABCD is changed to CAB. But after 10, we have another change. We had another opportunity because 2006, I talked to Brian, what's happening in the world? iPhone. 2006, iPhone. 2008, Samsung. No, it's true. I surprised. You know everybody cell phone in the past. We have never used it there. 2006, I invited one person from Georgia, not Brian. I pick up the friend call. He visited Seoul to give us some lecture for disaster. In Incheon Airport, he showed me the iPhone, Dr. Shin. Have you seen this one? So, what is it? Maximize, smaller. He's very proud of that. So I ran to some shop to buy. There was no shop. The iPhone was not introduced in Korea at that time. What's the meaning of the iPhone? It's a people who lived in the world now, about 70%, more than 80% of people now carry small computer in their pack, in their pocket. So 2010, 2020 means that everybody can access from the field, from the home, from the office, factory, commercial buildings, they can call to ambulance services as a system CPR is introduced. This is the 2015 OSTI meeting. We have declared now we should make a system, OSTI 10 steps and programs, and then which is very important for the system to make sure the increase in survival after cardiac arrest. In the past, we have developed a medical science and then education program, but it is not enough to make sure. We need more system-wise implementation of the program. From that point means system save lives. Dr. Sata told it this one before. So system CPR means everybody can be making one system. The system working together, each component under the system to work together on the basis of the same knowledge and skill. Not only the ambulance services, the paramedic and the first responder and bystander, sometimes family bystander, sometimes the street bystanders. They can work together. It is the system. System CPR is added to the team CPR, not replacing, added to the team CPR. From that meeting, and we have worked together, many community and the systems to benchmark each other and implement a system to save more lives. Why? We have found some very interesting topic. The compression, you only one thing, A, B, C, D, C, D, A, B, A, C, A, B, D, no matter. Compression is not solved at that time. So compression is mostly important topic now in resuscitation science. So very pioneers developed the concept. Hands-on CPR is equivalent to the AB, airway breathing circulation CPR is the same. So mask ventilation or breathing is little important for the special condition. So compression only CPR is spread out, and then it is very important for the system CPR. And the bystanders are now registered. It's amazing because in the past we just training, and every institution of the academic training centers report how many train. But now we are registered, name, address, and zip code, sometimes a phone number, and they are registered by themselves using the application. So this is very different change in last 10 years. And PADs, every city, every community now register. The level of the registration by the law, by volunteer, a little bit different, but the registration is one of the important issues because the PAD can be used by the system, not by the just only individual. So the system can link together bystander, first responder, ambulance, and hospital dispatchers can make a link, and then we can provide rapid response, which is one of the steps recommended by the OSTI 10 steps, GRA. And then high performance CPR is also the important. And then we can use the feedback CPR. And then we are designated cardiac arrest centers, which can provide a more high level of the intensive care, and then TTM, and then pacing, sometimes the coronary interventions. So this kind of system make change in outcomes after cardiac arrest. So the 2010 to 2020 is a major changes team CPR from the team CPR. In additional teams to team CPR, we added more important system CPR in the community. So what is expected for the next 10 years? Nobody knows. I just think about that. But what is the major game change in the next 10 years? 10 years are long? No, very short. Very short. And only we have 15 years of the cellular phone, you know, so very, very short time. So I'm expecting the next generation of CPR will be network CPR. I just naming the network. It's difficult to define, but I think network CPR means the system and system will be connected. What kind of system? Community system, and then EMS system and hospital system will be connected. So the first direction will be connected CPR, will be provided by the community, by the hospital, by EMS together. Why? First, audiovisual data transmission is very easy. Siriraj EMS is one of the best standard model. They are working together from the Siriraj EMS center, doctor, and field provider working together using the audiovisual data information. Real time, clearly, communication. There is something error, something broken, but it doesn't matter. We can look at together. We can hear the same thing. We can ask something to friend, ask something to family. We can get the information. We can give us some instruction. So audiovisual data is not miracle, not magic. It's it's now real world practice. So this is a picture from Korea. About 70% of CPR by the EMS provider is provided by the physician. Physician is working fire department dispatch center, sometimes hospital. They are working together because dispatch center recognize the patient who are collapsed in the street. They activate the bystander, and then they communicate with the ambulance for dispatching, and then they communicate with the medical director. They working together for like this. And then we use the commercial, the phone, not designated and customized devices. This is a Siriraj. I'm very surprised to see that. Very nice. And we can now install, we measured the feedback CPR data. In the past, we get the data only, and then it was analyzed by the medical directors, and then it can send to the each providers after 2 weeks or 1 week or 1 month. But now we have a setup, every data real time analyzed, and then real time see together. Dispatch center, hospital providers, and then ambulance services providers can see this data. So we can see from the feedback CPR device, we can see the, disruption. Everybody know, dispatch center, hospital directors, and the EMS providers, they know. This is real-time data communication can be provided. So it means in the past, individual and team working each community, each system, each EMS. But now they are working together. We are calling it connected system. CPR will be coming. And connected system is a network. From the ALS, BLS, community, first responder, bystander, physician, ambulance services, and then ER doctor, and then sometimes PCI doctor, sometimes neurologist. They can get, every time they can get the same information. It is not just a dream, real, it's coming. So connected all provide working for improve the quality and outcomes for cardiac arrest, all providers. It's a first change. Second, we will provide more personalized. In the past, and now we just do the same average treatment. Big size cardiac arrest, small ready, get the same epinephrine, 1 milligram by 3 minutes. Sometimes trauma, due to the brain trauma, or some chest trauma, they are TR after 2 or 3 minutes of CPR, done. We provide average CPR, but the patient is very different. The cause is different, the host factor different, risk factor different, but we give only average. Average means that from the diverse distribution, we can make some median or some mean, and then we can catch up the value, and then we give the treatment. It's why we don't know exactly what should be treated, what should be provided. So now almost will be changed. We will provide the CPR on the basis of personalized analysis, personalized information. Because more and more analysis show that the cardiac arrest is not the same disease. The cause is different, the substrate factor is different, the stimulation is different. So we can shoot what time in the field, what time hospital, which is the fast, which is the delay, which is better. Now we are analyzing data, those kind of risk factors for each individual should be used by the resuscitation. And the brain survivor is very different. For example, the cardiac disease and diabetes and hypertension, the all comorbidity is working for different outcomes, but we should use the information. How can we provide the treatment for the cardiac disease patient who are collapsed? Diabetes. This is a very interesting information. ESRD patient has no effect from the TTM, but we are providing TTM for all cases, like average treatment. The witness, blah, 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 we can provide. But we carefully look at the data. The ESRD patient is never treated. And sometimes hypersomnia is not effect for the diabetes, in particular, uncontrolled diabetes has no effect. So we should customize the patient, customized treatment should be provided patient. And then currently many places are working for the genetic analysis and the comorbidity, genetic analysis, and the interaction between the cause of the arrest. And then this kind of the genetic analysis can provide more information. And the genetic autopsy is one of the approach to what's the problem, what's the cause of this patient to be collapsed. So this kind of research will give more information about our customized individualized care, personalized care. So another one is the data set from the society has many information about the people. For example, Singapore and then Denmark now use the patient, the private information of the health. They can link the past medical history, current medication, and then those kind of information can be linked for the field care and emergency care. We in Korea, we also have the national insurance information. It's the biggest information for each person's health status. And then we are linking the information to be used in the prehospital care. So this kind of age, gender, or time factor, it was generally recognized by the resuscitation science before. And then we can add more medical record, personal medication, and genetics. These kind of factors can be used for the decision. And also we can use some point of care laboratory. And Siriraj has a test something, but we can use more ultrasound and some laboratory tests can be used for the patient to be identified for the personalized care. Third is a more effective circulation should be provided. For the rest of 50 years, we have not reserved the circulation. Only we developed a mechanical compression device. It is equivalent with a human man's hands. So, but in more pioneer now trying to start to provide ECMO, which is the airway breathing circulation done by the ECMO. But ECMO is the problem is that it's not easy to implement. It is not insert. But the more and more smaller, simple, small size ECMO is introduced. Now UK and French, German, they use ECMO in the helicopter and the field This kind of the activities can be used for the maintaining circulation. It is one of the some option. How can we provide early circulation? But non-physician extenders, it's not easy to perform ECMO in the field. It is one of the difficult problem in prehospital care. So now Minnesota group has developed a mobile ECMO team. They have working together with dispatch center. They can send the ECMO team to the free hospital and the other small hospital to provide ECMO to give more early circulation. In Korea, we have about 3,000 cases of ECMO for the rest of 15 years, but most cases are receiving the ECMO about 40 minutes after collapse. That makes sense. So this is one of the important approach. And then protocol is like this from the cardiac arrest, and then every system activated. And then first responder coming, and BLS coming, ALS coming, and ECMO coming. The patient is alive, come back. Patient is still resuscitated there, and they're starting to insert ECMO. And this is very popular in France. They have a very strong physician ambulance services, and they provide ECMO in front of the Mona Lisa in Louvre Museum, and then the subway, and then street and supermarket. They provide ECMO in the field and building and the museum. But it was only instant report before. But now I think it is very promising, challenging but promising strategy to provide early resuscitation. So prehospital ECMO is tested now, discussed, and then the ECMO activation protocol discussed. Siriraj is only one place to provide critical life support for the neurologic disease, stroke. You have a CT stroke ambulance. It's only one place in Asia, about the so big land in Asia, but only one place. So I think you should start to provide some as a pilot. I'm not sure, but it is not replacing the BLS and ALS. It should be added to or combined. So ECMO CPR in Korea is increased, but our concept is that in the future, early ECMO CPR will be provided after DA CPR or conjoining with DA CPR. Dispatcher recognizing very quickly and then giving instruction for bystander, and first responder activate, and BLS and ALS is coming to the field. At the time, simultaneously, ECMO team is going to the field in the small hospital and provide the early resuscitation for circulation. So physician-directed resuscitation, it's one of the direction, because in the past each system has operated by each system providers, but now system can be linked together, information shared, and then physician is not only hospital but also protocol-based direction. We can see together from A to Z, from the starting to end. We can see the physician supervise, sometimes more directly engaged to the care. 5G, IoT, data transfer, the mobile. And all providers are really connected. So chain of survivor can be changed to network of survivor. And then we will have a 3-pillar connected CPR. It can provide high quality basic life support, and the personalized resuscitation can provide more definite, more clear ALS. And then critical care life support using ECMO to guarantee for the perfusion, the early perfusion. And then which things are that covered by physician, then the other person. So physician-directed resuscitation is a scope of the future direction. Okay, we can make a connection. We can get the data real time, and then we can, if needed, provide directly for the more invasive technology to be used in the field. So from the connected CPR, personalized CPR, and ECMO CPR can be achieved by the physician effort, physician-directed resuscitation. So what will be changed from A, B, C, D? Now in the center, I'm delete this the new delete the C, A, B, but C, A, B, D, E will be coming. So it is one of the direction, but it is not finalized by the physician extenders. The physician should work more hard, more sensitive. How can we make better system? Thank you very much.
Any question from the audience? Very interesting topic. Very interesting. And like we're in like going into the near future. Like
Sorry.
Okay, any question from the audience? Oh, we have one. Oh, we have the compliment that the presentation is wonderful.
Yeah.
From the online.
Ming?
Yes.
Yeah, Dr. Ming.
Hi, Professor. I'm paramedics from Chulalongkorn Hospital. So in our hospital, we also have the role of ECMO CPR in our hospital, but we are a different strategy. Like in our setting, we have an EMS team to provide an ACLS in our hospital. And then if you suspect some cause of arrest, mostly from heart disease, we're gonna activate back to our hospital and do a ECMO CPR in emergency department. So my question is, we all have different strategies. So what about the main difference? Like we bring patients to the ED or we bring the ECMO to our hospital? Like
good question. Good question is difficult question. But yes, actually the critical life support is a new one for EMS, but now from the neuro CT ambulance, and then some Reboa for trauma nowadays they are using, but some systems are not used in the ER, even though we should activate thoracic surgeon or cardiologist. They always working well together. It's the political talk, but they usually resistant to the work. So we should talk and we should invite them engage, or sometimes we should train by ourselves. We can start. But many European countries now use the ECMO in the field. It's a very important solution. In the past, I think you remember this ultrasound. It was not used in the pre-hospital. But now many systems are using ultrasound. So it does not show some beneficial now, but it used for some screening for the torso injury, for example, like this. In your hospital, and the other department has a priority or the power to use, and then they should be activated. But the pre-hospital care setting and then EMS center has a few resources. I understand. But you know, where is from the Chao Phraya River? Very north. Where to go? Bangkok Bay. Everybody want to block? No block. It's a big river. It's never stop, never sleep. Okay. Means the direction and perspective cannot be prohibited. The patient want to live. They need early circulation with very stable model. It means you or your friend in cardiology, one of them should respond. Doesn't matter. You can invite the other department, or you can design small pilot, one of two. We are preparing in Seoul. We use the ECMO in my department. My department team provide ECMO for resuscitation, but the cardiologist and thoracic surgery, they are also use the ECMO, but they use the ECMO for their practice. So we are now extend our scope to the pre-hospital setting, but not guarantee. It takes a time, but who will do it? Job price still flow from the high to low. That's my answer.
So what about the time that our patients who candidate ECMO, we need to achieve the pre-hospital time not over than
Yes,
40 minutes.
I know.
So how about you? What the time that you spend to bring the ECMO CPR to the scene? Is that a go time?
Yes, very, very important. So the BLS and ALS as a current system should be strengthened and then should be standardized. It is the first principle. We can add more survivor. If our basic service is broken, to delay, the patient cannot be survived. So first, layperson should start CPR early and then maintaining the blood to the brain. And then the ALS starting more different airway, blah, blah, blah. And then CLS team can give some more definite care. So your question is that your system is a little bit delayed for the basic support, or the general population is not doing many resuscitation, even though they with 70% witnessed, but you should educate trains first and then give them more effort. And also you can have some perspective. What's the next step? You don't follow every step because it takes 30 years. You die, me die, everybody die, and then next generation can get the same level? No, we can jump. We can jump because it is benchmarking. So I think you start to stimulate and encourage the BLS system and prepare the more effective resuscitation. It shortened about the 20 years.
Thank you for your questions.
Okay, I have some personal question, which is also the question from the online. So I think the future direction might come in your way, but do you have a data on the cost effectiveness? I know life is invaluable, but do you think we should add ECMO CPR and those personalized CPR should we incorporate all of these things into the protocol, or we should individualize, like individually employ this system?
Yeah, a little bit confused question, but
Yeah.
I think that this is a kind of a perspective, and it can bundle will be introduced, and then it can make a new different quality of the system will be made. So personalized CPR is very difficult naming. But most department science are trying to make this kind of personalized, because the first part is a cancer treatment. They are using already every cancer now is that they tested the genetic susceptibility for drug and complication and the choice of the treatment. And then this kind of modalities expanded to the more chronic disease. It is one of the trend. So one part is from the personalized care, the other is the more system care, the other is the more individual invasive care. But it is what we are going to there. Where is our destination? I'm just talking about that bundles are working together, but I'm not sure which is how can standardize, how can make some protocol. It is we all should work together to make that. Yeah,
that's one of them. And I'm glad you mentioned cost effectiveness, because like anything, having data is important. There's a lot. It's not a new technology, eCPR, but there needs to be obviously a data-driven approach to this.
Yes.
And the challenge that the debate is, if you had $5 million in a community, would you spend that on developing an ECMO program that's available 24/7, or would you use that $5 million to train the bystanders? You can't answer that, and every community is gonna be a little bit different. But the idea is, if you're not doing the basics, then everything that follows after is really going to be inconsequential. ECMO historically is, for the tip of the pyramid, it's a small subset of patients. And when you look at some of the criteria, there's not even agreement yet as to who should be getting ECMO. This is again a new concept, but there's more literature that's coming out, there needs to be a greater focus on a cost benefit decision, because it ultimately is about saving lives. And the debate would be, do you put greater investment, in the community that's going to have, a bystander component that's raising your bystander CPR rate, so more patients will qualify for ECMO, right? Again, or are you just putting this, at the back end for a very select number of patients? It's not an easy question to answer, but you have to use data to drive these decisions. I think we all agree on that. And over time, there's going to need to be greater understanding about being able to measure this in different communities, different countries consistently, because even the large European studies, it took several years of data to be able to because it's not that many patients that are getting this. But over time, those numbers will likely increase, but you're going to need to use a data-driven approach, and cost benefit has to be part of this discussion. We were having a discussion yesterday. In resuscitation, sexy always comes to the front, but the basics, so sometimes we ignore, you can't jump over the basics. You have to do the basics well before you can go on to advance. So it's really, it's looking at this from the point of view of the entire picture, the community piece, the pre-hospital piece, the hospital piece. And if you're going to insert greater resources, putting them where they're going to have the greatest impact. But it's exciting to hear talks like this.
Yeah. Okay. Thank you very much, Dr. Shin. Please give him another round of applause.